So this is the view of bronchoscopy. So what we can find here is thick secretions from the bronchial segments. So this, so as we can find here, secretions are clear. After clearing, you can find it. You can see the normal bronchoscopy. So secretions are noted here. So how do we start on antibiotics for HAP, VAP, and everything? So in order to start an antibiotic there, we should know first what is the ideal, what is the proper microbiome. Like in every hospital, there is a antibiograms are available for the particular hospital, like which is the most common organism which usually occurs in the hospital, and whether it is an MDR bug or non-MDR bug. So we usually look into that. So when we look into that, we can tailor antibiotics so that we can use proper antibiotics which work, and we can remove the unnecessary antibiotics additionally. So we should know local antibiotic. So history of IV antibiotic usage. This is a very important thing. Like if the patient has been into any center and he has used an antibiotic in past 3 months, like 90 days, it can be an MDR bug. So if he has not been treated properly, or if the antibiotic dosages are not sufficient, the patient could have gotten the same bug with more resistance, and it could have caused an infection. So that can give a clue. And if the patient is usually presented with upon arrival to your hospital, we should keep in the mind before starting any antibiotic. So the table which I mentioned here is, first table shows no high risk mortality and not likely of MRSA. Usually MRSA is not a community acquired thing or thing. Few hospital acquired pneumonia hospitals doesn't even have MRSA. So only few hospitals do have MRSA. So if we know the local antibiotic, so we know that whether we want MRSA coverage or not. So usually one of the following antibiotics of beta-lactam things: piperacillin, tazobactam, cefepime, and ceftazidime avibactam. So these are mostly used. So the next is levofloxacin, like levofloxacin 750 milligram, and imipenem, meropenem. So one of the following, like anything from these three groups, are used if there is no high risk of mortality and it is not an MRSA. So if you suspect it is an MRSA and still it is not, there is no risk of high mortality, you can use one from these groups like piperacillin or cefepime or ceftazidime, or levofloxacin, or carbapenem group like imipenem, meropenem, aztreonam. Aztreonam is kind of narrow thing, so usually they won't differ unless you know the proper culture reports. Plus, you can add vancomycin, which is a standard thing for MRSA. So 15 mg per kg IV. So 12th hourly, 8 to 12th hourly, depending upon the patient's severity. And next thing is linezolid. So linezolid is usually preferred because of less nephrotoxicity and more bioavailability. But it is a bacteriostatic drug. So these are things which we can consider if we think about MRSA. So if the patient has high risk of mortality and he has used IV antibiotics in past 90 days, so he has come from other center. So what can we use is two of the following, like not two beta-lactam group. We can use one from beta-lactam group, another from any other group like fluoroquinolones, anything, or aminoglycosides. Plus you can use the same vancomycin or linezolid, anything. So two from the upper group, like anything like from here, any two antibiotics along with vancomycin or linezolid. So usually 3 antibiotics are given if the patient is high risk of mortality and usage of antibiotics prior 90 days. So VAP treatment considerations is like a little bit similar to HAP, but something adds on here. So same thing, like MDR bugs usually differ in VAP, like ESBL. ESBL is nothing but extended spectrum beta-lactamase producing enterococci. Like Enterobacter. So Enterobacteriaceae. So Enterobacter is a very notorious bug, which is usually harvested in the pharyngeal secretions. So in cases of patient with VAP, we do give stress prophylaxis. We give more PPIs like pantoprazole, continuous infusion also given in certain centers. So what happens is usually the acidity of the stomach is lost, so it becomes a reservoir for organisms. So many organisms are there in the stomach and digestive tract, so that these organisms are aspirated into the lung. So they get infected and they land up in lung. So these are the organisms we should suspect in ESBL. And CRE is nothing but carbapenem resistant enterobacteriaceae. So both are enterobacters. So this is carbapenem resistance, extended spectrum beta lactamase. So both are very much a serious thing. And Acinetobacter is a very dangerous organism, which is, if it is an MDR thing, it is very, very dangerous. So it's very difficult to treat. So Pseudomonas aeruginosa. And if the patient has come from any other center recently, so we should check into the antibiotics which they have taken in past 2 weeks. So better not to use the same class. So next thing is dosage modification for altered pharmacokinetics. So any drug, whatever we are giving to the patient, we should know they act upon the pharmacokinetics. Like few drugs are concentration dependent. Like if you're using any aminoglycosides or fluoroquinolones, they act when they reach a certain concentration. So it's a concentration dependent antibiotics. So they are given only once daily dosage. So other things are time dependent. So time dependent things like the area under the curve suddenly comes down. So in order to maintain the area under the curve, you should give like antibiotics in frequent intervals. So these things we should know before treating any patients. Like what does the patient require? How is the patient's fluid circulation all over there? And how is the availability? So we should know before giving any antibiotic, choosing any antibiotics. So in certain patients, there is prolonged duration of infusion of antibiotics will be needed, so that these things can be managed there. And developing dose-based regimens on MIC, like if you are giving any culture report to any microbiology lab, they give a value, MIC value, like minimum inhibitory thing. So based on the value, we have to choose the antibiotic. That is the idea behind it. So creatinine clearance. Next is the patient is intubated. We have to regularly monitor the output and creatinine clearance. And weight of the patient is also needed to give a proper dosage. And we have to de-escalate. Like if you are putting a patient in ventilator, you are sending for a culture. If you are getting culture reports, and you should narrow the antibiotic as soon as possible. That is the idea behind sending a culture. So we are starting with the broad spectrum antibiotic. You have to make it very, very narrow whenever it is possible. So prolonged usage of antibiotics should be avoided. Prolonged usage promotes colonization of antibiotics. So colonization of antibiotics is very bad. So usually in many studies, it has mentioned that prolonged usage has now superiority over antibiotic usage from 7 to 10 days. So for certain conditions, right, in case of empyema or a parapneumonic effusion, antibiotics are usually given for weeks together. But that doesn't mean that every patient should receive antibiotics for weeks. So in case of proper pneumonia, antibiotics, it's not more than 10 days, 7 to 10 days. So we have to de-escalate whenever it is possible. And we should also know certain things that are not mentioned here. But if the patient has any recent viral infection, patient can, it usually promotes a patient to get a streptococcus infection, usually, because the viral infection do activate a platelet activating factors. They tend to adhere themselves to streptococcal organisms. So if you are suspecting a post-viral patients, usually we should cover them for streptococcus. So next thing is aerosolized therapy. So aerosolized therapy is upcoming now. As we can see, is an ultrasonic nebulizer machine here. So the antibiotics are used with this nebulizer. So the benefit of the aerosolized therapy is actually not proven in any studies. But what we see here is a quicker resolution of consolidation, like it directly enters the lungs, and the concentration levels are actually very quick. So usually, if you're giving an IV antibiotic, the concentration levels take a time. So in case of aerosol therapy, it reaches very quick. So there is quicker resolution of consolidation. So, but it is not often encouraged. It is used only in case of MDR pathogens. So, or if the patient has anything like CKD, or you can't give an IV antibiotic, so you can go for a nebulized therapy. Usually, it is reserved for aminoglycosides, like tobramycin nebulization can be used in case of Pseudomonas, or cholesterol nebulization can be used in case of MDR pathogens. So antibiotic distribution, when antibiotic distribution is low, if the patient has very poor pharmacokinetics, so we can use this aerosolized therapy. Actually, prevention is better than cure. That is the thing here. So VAP is very difficult to treat. So VAP causes financial burden to the patient. It increases the day of stay in hospital, and it poses a great challenge to treating physicians. So better to prevent them than to treat them. That is the idea behind that. So usually infection control team in the hospital should take care of this. So adequate space, lighting, and proper ventilatory systems should be there in the hospital ICU. Hand hygiene should be maintained. So for each patient, we are attending any patient, first we should do is a hand wash or hand rub, whatever alcohol-based rubs are available there before touching any patient there. Next is adequate nursing staff to minimize the movement. So if the patient, many hospitals do have a problem that adequate staffs are not available. So they tend to look 2 to 3 patients. Like each staff do attend 2 to 3 patients. Among 3 patients, if a patient has MDR bug, they tend to carry it, so that other patient also will get infected. So adequate nursing staff should be there to minimize the movement there. So attention to aseptic precautions. So in ICU, many procedures are done there. So each staff should observe the aseptic precautions which are done in the ICU, and they should observe that how the physician or how the consultant is doing the procedure very much sterile, and they should also maintain the thing. So decontamination of equipments like nebulizers or the circuits or HFNO systems, so they should decontaminate it as per the requirement protocol. So these are things which they can do, like anyone can do. So there are, like anyone in the sense, these are conventional methods. So specific methods are there. So specific prophylaxis is there. Specific prophylaxis is nothing but improved methods of sedation. Sorry for the spelling mistake there. Sedation. So improved methods of sedation. As I mentioned earlier, the sedation is like improper sedation or more sedation can increase more aspiration there, like after extubation also, like during the time of intubation also. So sedation methods are there are many improved methods of sedation available, so that those should be used. And accelerate weaning, like if the patient shows any sign of improvement, the treating consultant or ICU consultant should accelerate the weaning process so that the days of stay in ventilator is reduced and patient is taken off from ventilator. So if the patient is taken off early from ventilator, he has very less risk of developing a VAP. So maintaining the cuff pressure. So if the patient is intubated, cuff pressure should be maintained about 20. Like if the cuff pressure is low, the secretions do pool above the cuff and they tend to go inside. Like they tend to develop a biofilm. So during each and every secretion, it is pushed inside and they get a VAP. So semi-recumbent position, usually it should be done on oral hygiene is nothing but the patient adequate oral hygiene, like oropharyngeal secretions tend to pool in the above the ventilator intubation cuff. So those oral hygiene should be maintained so that the colonization of very pathogenic bacteria is prevented. So usually patients who are in the ICU or hospital, they get colonized with a very pathogenic bacteria. So these colonization should be prevented can be prevented with adequate oral hygiene. Selective decontamination digestive tract, like what I mentioned earlier, usually the aspiration thing can happen because we use more amount of PPIs and H2 antagonists. So the abdomen, like stomach, tends to be reservoir. So selective decontamination of digestive tract, it's actually using an antibiotics, topical and systemic, a short course to decontaminate, like Cetran and topical aminoglycosides acids are used in place of selective decontamination of digestive tract. So studies have shown that selective decontamination has prevented the mortality and recurrent infections in ventilated patients. Next, but last but not least is vaccination. So vaccination is a very important thing here. So vaccination can prevent pneumonia. So mostly pneumococcal pneumonia is the most common cause of pneumonia. So children usually do have this pneumococcal vaccination in their schedule, but adults, if the patient has any COPD or bronchiectasis, cystic fibrosis, or if they do have any malignancy or anything like heart diseases, they can go for a pneumococcal vaccination. Actually, pneumococcal conjugate vaccine 13 is available here. So PCV 13 is given there. So after PCV 13, they can receive a PPSV, like polysaccharide vaccine, 23, which covers 23 variants. It is given after a year after PCV 30. So these are the things which can be done to prevent an infection and prevent a mortality. So these are things which can be done to prevent any pneumonia. So pneumonia is curable, but stupidity is not. That is the motto here. So healthy lungs for all. Thank you.